Yes, ma'am. Good afternoon, everybody, and I'll be talking about an important topic which is important in the current scenario. So if I make a statement that among the kids whom we are seeing in our day-to-day practice, 1 out of every 3 children is either overweight or obese, I think everybody is going to agree with me. This is the current scenario at present. So introducing the new pandemic, childhood obesity. So the COVID-19 pandemic, which has led to school closures, disrupted routines, increased stress, decreased physical activity, and improper nutrition in children, has paved the way for a new pandemic, childhood obesity. So this was a study which was published by the CDC weekly report, which was done in the US, and it included children between 2 to 19 years of age, and it was found that the rate of BMI increase approximately doubled during the pandemic as compared to the pre-pandemic period. So this is the same scenario everywhere. And hence, along with prevention, at present, diagnosis and management of children with obesity is the need of the hour. And that is what I'm going to talk about today. So the scope of my topic today is going to be identification of obesity, identification of the cause of obesity, the comorbidities associated with obesity, and treatment. Treatment in the form of intensive lifestyle therapy, including diet and physical activity, pharmacotherapy, and bariatric surgery. So let's go into it. How do we identify obesity in children? So gone are the days when we look at a child and say, oh, this is obese, or maybe overweight. This one, so what does this look like? Or for that matter, this child. Sometimes you can compare. Oh, so this had to be of this, this is the same age child who's the normal child on that side and the older, the bigger child on this side. No, we need to accurately measure the weight and height of the child. It has to be plotted on age appropriate growth charts. So we are all aware of IAP growth charts for girls and boys between 0 to 18 years. And what chart I have put up on the left side is the weight for length or weight for height chart for children below 5 years of age, wherein any value which is beyond the 99th centile is considered to be abnormal. And on the other side, the chart is a BMI chart where any value beyond 23 adult equivalent is considered to be overweight, and beyond 27 adult equivalent is considered to be obesity. So, for example, there is a new pediatrician-friendly IAP growth chart. Now, this growth chart has a small box on this side, which when made bigger, shows that this is a weight for height chart for children who are more than 8 years of age. So this is actually a very quick BMI screening tool, which does not need the calculation of BMI. So routine practice, when we are quite busy, it's quite difficult to calculate the BMI. So we can just plot the weight of the child for that particular height and decide if this child is overweight or obese. So that is how important it is to understand that we have to plot the BMI of the child on the chart to understand if the child is appropriate for his age. So this is an almost 2-year-old who has a height, who has a length of 91 centimeters, which is just below the 97th centile, and weight is above the 97th centile. And when we plot the weight for length on the weight for length chart, it is way beyond the 99th centile, confirming that the child is obese. If we take a bigger child, this child has a weight for a weight and height just below the 97th centile, which appears to be okay on this chart. But when we plot the BMI on the BMI chart, then we realize that this child is obese. So just plotting the height and weight on a chart is not enough. We have to calculate the BMI to decide if this child is overweight or obese. So once we identify that this child is obese, we need to know what is the cause for obesity. So if you look at it, if there's a child who has obesity with accelerated growth, so that is their height is normal or is increased, the cause is exogenous, which is nutritional. It is because of increased calorie intake. On the other hand, when there is an obese child with short stature, then the cause is endocrine. It could be either hypothyroidism, Cushing's, or growth hormone deficiency. When we have a child with obesity, which is early onset, before 5 years of age, extreme obesity with very classical clinical features, dysmorphism, developmental delay, or some deafness, retinal dystrophy, think of genetic obesity syndromes. When with obesity, who had history of hypotonia, feeding difficulties in the first year of life, then hyperphagia, hypogonadism, mental retardation, think of Prader Willis. When we have a child who is obese with mental retardation, polysyndactyly, brachydactyly, pigmental retinopathy, think of Bardet-Biedl syndrome. And similarly, when obesity is associated with retinal dystrophy, deafness, diabetes, progressive pulmonary, renal or hepatic dysfunction, it is nothing but Alström syndrome. So we have to take into consideration additional features and decide what is the cause for obesity. I actually had to include a slide on genetic cause for obesity. Though it is a rare cause of obesity, it accounts for only 5 to 7% of extreme obesity cases in children. But it is important to understand that now we have therapies. We have some targeted treatment for certain genetic conditions. And that is why we should know how to proceed when we suspect that a child has genetic cause for obesity. The first step is to ask ourselves if this child has developmental delay. Yes, if he has features of Prader-Willi, get a methylation test done, confirm Prader-Willis, else try to rule out Bardet-Biedl, Alström, or Albright hereditary osteodystrophy, which has hypocalcemia and pseudohypoparathyroidism. If there is no developmental delay, there is a defect in the leptin-pro-opiomelanocortin pathway. Check for levels of leptin. Undetected leptin levels indicate it is congenital leptin deficiency, can be treated with leptin injections. Check for levels of insulin and proinsulin. You can pick up PCSK1 deficiency, which is nothing but the prohormone convertase deficiency. And when this is negative, you can do molecular genetic studies to rule out other causes. These are rare causes, but we have therapy. We have MCR4 agonist therapy, which is set melanotide, which can be used for a few of these conditions. So it is very important that we not only diagnose these conditions, it helps us to provide genetic counseling for subsequent kids, and it helps us in management in general. So this child who's obese, see his weight is on the 75th centile. His height is way below the 3rd centile. His BMI is high there on top. But this child has obesity with short stature. This is an endocrine cause for obesity. He had acquired hypothyroidism. So just by plotting it on the growth chart, you can actually pick up what is the cause for obesity. The third point, we look for comorbidities. Comorbidities are common in obese and overweight children. In fact, higher the obesity, higher are the chances of comorbidities. So please actively ask for polyuria, polydipsia. You may pick up type 2 diabetes. Look for skin pigmentation, acanthosis nigricans, skin tags. It indicates insulin resistance. Ask for history of snoring, apnea, daytime somnolence, hyperactivity, headaches in the morning. It indicates obstructive sleep apnea. Ask for abdominal pain, indigestion. It not only indicates reflux, it may also indicate non-alcoholic fatty liver disease. Musculoskeletal symptoms. You may pick up slip capital femoral epiphysis, Blount's disease, osteoarthritis. Hirsutism, acne, irregular menses in females indicate PCOS. Boys usually come with gynecomastia. And look for psychosocial comorbidities, which is usually associated with obesity, depression, anxiety, bullying. There could be eating disorders and substance abuse. Look for comorbidities everywhere. Whenever you see an obese child, you may miss this. See, this is acanthosis nigricans. This child came to me in the OP yesterday. He had lost almost 7 kg weight in the last 2 months just by following lifestyle interventions. So this is acanthosis nigricans. This child came limping and he turned to have a slip capital femoral epiphysis on the right side. And this child is one with Blount's disease. So all these comorbidities do exist with obesity. Whom do we screen for comorbidities? Any child who has a BMI which is beyond the 85th percentile, that is corresponds to 23rd adult equivalent on our IAP BMI charts, have to be screened. You need to do HbA1c, blood glucose levels to rule out diabetes, fasting lipids to rule out dyslipidemia, check the blood pressure, compare it to the normal standards to rule out hypertension, check for SGPT levels to rule out non-alcoholic fatty liver disease, check for androgens if there is history suggestive of PCOS. If there is obstructive sleep apnea, he may need referral for sleep studies. And if there are psychosocial disorders, you may need appropriate psychiatric referral. So when you identify and screen for comorbidities, you're able to diagnose it in time and provide adequate treatment. Now let's start with the treatment. Treatment has 3 parts. One is intensive lifestyle therapy, pharmacotherapy, and bariatric surgery. So when I talk of intensive lifestyle therapy, many times, When I start talking about the diet, the first thing the parent tells me is my child doesn't eat anything. See, basically, our children have a lot of access to and a supply of calorie-rich, ultra-processed, carbonated, caffeinated, and highly calorie-dense junk food, and which is going to give excess of calories to them. So our initial lifestyle therapy starts right from modifying the diet. So it starts right from infancy. We need to start good eating habits early on. Dietary modification not only prevents obesity, but it also helps to reduce weight in a child who is already obese. So we start and we encourage breastfeeding, exclusive breastfeeding for the first 6 months. We introduce complementary feeds only at 6 months. No juice, sugary beverages, or any fast foods, no force feeding. You've seen kids being actually loaded with food. Child is refusing, mother is just pushing it inside into the mouth. Age appropriate portion size, praise for trying new food, encourage infant to feed themselves. They will stop when they are full. Family-based meals so that the child sees how the other members are eating and develops good eating habits. Children who are toddlers are actually very active unless you force them to sit in one place with a device in hand. So please don't allow screen time for these children. Allow them to be active on the floor. Ensure they take adequate amount of sleep. No screen time for any child below 2 years of age, and minimum screen time for children between 2 to 4 years of age. No TV in the bedroom and while eating. And these habits have to continue even when the child grows older. A young child needs 3 meals, 1 to 2 snacks, 2 fresh fruit servings, 4 to 5 servings of non-starchy vegetables, all meals on table, not in front of TV, no sugary beverages or fast food, and dessert only on special occasions. We have kids who eat desserts every day. So we have to bring into the habit. The habit has to come into the lifestyle. Parents should act as role models. So they have to eat well so that the child sees and follows them. These children, in addition to their daily activities, need moderate to vigorous activity in the form of structured play, organized play for 60 minutes in a day. See, as a child becomes older, he becomes less active. So we have to ensure that this 1 hour per day is put into his daily timetable. He has to have adequate amount of sleep. Disordered sleep interferes with the metabolism and causes obesity. So sleep is very, very important. Screen time less than 1 to 2 hours. Restrict non-academic screen time. See, what happened during this pandemic was academics was all screen time. So we had no other option. So the strict rule is, except for academic screen time, no other screen time. Routine sleep pattern, no TV and electronic devices in bedroom. So the next thing is about physical activity. So physical activity, when combined with calorie restriction, actually causes a lot of change in the child. And when we talk to parents, mostly they will say, everybody in our house is obese. It's genetics. So it's not like that. Everybody is obese because nobody is exercising, right? So we have to include physical activity into the lifestyle. There are various forms of physical activities which can be provided to the child. You can have aerobic exercises, muscle strengthening exercises, bone strengthening exercises. And these charts, we usually prepare these charts and ask the child to choose one among them. So there are a lot of options and everything can be encouraged. So the child actually selects 1 or 2 of these exercises of his or her choice. It is more of a fun activity rather than therapy. So these are behavior change techniques. I think it's a common misconception that lifestyle changes, lifestyle modification does not cause weight loss, or if it causes weight loss initially, the child starts gaining weight again. It is absolutely wrong. There is sufficient evidence to prove that adequate intensive lifestyle modification therapy definitely brings about a change and is the most effective tool for pediatric weight control. So it's important that we all support intensive, age-appropriate, culturally sensitive, family-centered lifestyle modification therapy. It's important to make it individualized for the child and for the family. So we have to sit with the family, we have to sit with the child, find out where are the problems, where are the issues, and accordingly give them correction. You can't have a tailor-made chart for, it has to be individualized. You need to restructure the environment so that sometimes the child will say that they come late after tuitions, it becomes late in the night. So you put the play activity in the morning, or you split the play activity into 2 halves. So you have to restructure the environment, ensure and identify a role model for the child at home. So you could be a parent or a grandparent who will actually supervise whether the child is taking diet properly, whether he is doing activity, and will give him the necessary boost and encouragement. So you need to have a role model at home, and it is also important to take care of the associated psychosocial factors involving the school or the community. So if you have nutritional classes in the school, some physical activities in the school, and in the community, you could have some camps. So all this is going to make this therapy more effective. So does it work? So we have studies. Now this is the Endocrine Society Task Force study, which actually commissioned a systematic review to find out the effect of lifestyle changes in children between 6 to 11 years of age. And what they found out is that diet, physical activity, and behavior change brings about a small reduction, a small short-term reduction in BMI, BMI score, and weight. Though it is small, it is significant because these children are growing. So the linear growth is going to take place. If you're able to control and sustain this weight for a year or so, the child's BMI automatically drops. Similar studies in older children between 12 to 17 years also showed the same findings. And this was a study where it was a randomized control trial where, in addition to the intensive phase, they actually pulled on and had a maintenance program for 2 years. So which showed that if you adequately supplement with a maintenance program for 2 years, the child lost weight, the children lose weight in the first 4 months. This is the intensive therapy. And then for 2 years, the weight loss was sustained. So it is possible to sustain and maintain the weight if we are able to provide the maintenance schedule where you continue with the diet and the physical activities. What happens because of all this? Because of all this, the BMI reduces, the weight reduces, and according to this study, you could have a drop in the systolic blood pressure. It improves the lipid profile and improves the cardiometabolic outcomes. So it's really very effective, and we should all make it a practice now to ensure that we guide our patients accordingly. Pharmacotherapy is indicated only when intensive lifestyle modification fails to limit weight gain or to take care of the comorbidities. It should be used along with concomitant lifestyle modification program. You should be aware of the potential adverse reactions, and you should discontinue the same if the patient does not have an improvement within 12 weeks of taking full dose of the treatment. So there are drugs which are approved by the FDA. They're basically approved for adults and can be applied for children more than 16 years of age. The only drug which is approved for children between 12 to 16 years of age is Orlistat. The indication for use is BMI more than 30 or a BMI more than 27 with at least one comorbid condition like hypertension or diabetes. There are other drugs which are not approved by FDA for obesity, but they definitely cause a bit of weight loss and can be indicated in selected scenarios. For example, growth hormone in Prader Wili is supposed to reduce the body fat, increases the linear muscle mass, improves the height, and increases the energy expenditure and causes weight loss. Similarly, octreotide for hypothalamic obesity, leptin in leptin deficiency, and metformin indicated in children who are more than 10 years of age and have type 2 diabetes or have obesity or are on atypical psychotropic medications or PCOS. The concerns are most of these studies are in adults, and the effect of we don't have a lot of studies related to pediatric population, and as I mentioned, pediatric obesity is a chronic condition. So the long-term success is much more important than short-term gains. And the last about bariatric surgery is indicated in a child who has completed puberty, has achieved his final height, has a BMI of more than 40 or more than 35 with comorbid conditions, and there is no response to a lifestyle therapy or with or without pharmacotherapy. We need to have a proper psychological evaluation so that you understand that the child will tolerate this procedure and will be available for future proper follow-up, and adequate dietary and healthy activities will be followed even later on. There are various types of bariatric surgeries. Restrictive, where you decrease the amount of food by limiting the size of the stomach by either using a band, which was used in the past. Nowadays, vertical sleeve gastrectomy, where 85% of the stomach is resected, or it could be malabsorptive, where you change the anatomy of the intestine so that the absorption doesn't take place. For example, you divert this. This is a biliopancreatic diversion. You divert the pancreatic juices away from the food content. So it's not going to get digested, malabsorption takes place, or a combination of both. The most common being Roux-en-Y gastric bypass surgery, where you have restrictive as well as malabsorptive component, and you have a variety of new such surgeries which are coming up. But do they work? Yes. In children who are extremely obese with comorbidities, this study showed that compared to those children who did not undergo surgery, they had a significant drop in BMI, irrespective of the technique which was used for bariatric surgery, and it was sustained for almost 5 years. Not only this, it also helps in the resolution of comorbidities. So if you look, diabetes, pre-diabetes, hypertension, almost 100% resolution. So this is definitely useful in a child who is extremely obese. The role of this in children who are not in that category is not known. So finally, the take-home message, family-based comprehensive multidisciplinary behavior intervention, which is focused on lifestyle modification and supported by the family, school, and community is the need of the hour. Evidence of pharmacotherapy and bariatric surgery treatments is not much clear. And that is why we all should practice practical and evidence-based approach to diagnosis and management of children with obesity. Thank you. Thank you, ma'am.
And I hope, especially the pediatricians, we should inform the parents how they should feed the children, which is the homemade preparation.
Yes, ma'am.
They should take it same table, not from fast food.
Yes, ma'am. Thank you, ma'am. Thank you so much.
Thank you for the enriching talk, ma'am. I now request the chairperson to honor the speaker.